This is a presentation on status epilepticus in children. It is intended for hospital-based clinicians and those who take care of children in emergency or urgent care settings. I have no disclosures. I would like to thank Dr. Agnes Chen from the Division of Pediatric Neurology at Harbor UCLA Medical Center for providing expert content review as well as feedback and evidence-based science to ensure the quality of this presentation. In this presentation, we're going to go through the definition of status epilepticus. We're going to go through epidemiology and etiologies for status epilepticus. We'll talk a little bit about assessment and diagnosis, as well as management and treatment considerations for status epilepticus. Let's take a case. Imagine that you're working in an emergency department late night, and early in the morning at 3 a.m., your nurse informs you that the paramedics are about to bring you an 11-month-old female who is actively seizing. However, no other information is available at this time. The question is, what do you prepare for this arrival? What other information would be useful to have? I know I get this very often at nighttime when we're having seizure runs. And the important thing for me is, first of all, communication. Make sure that the team is aware of what we're getting, have a brief team huddle or a briefing, and assign everybody their roles. Take a little bit of an estimate about the weight using the Broslow based on the patient's age. Prepare for any kind of airway equipment should you need it. Also, it is likely that the patient does not have an IV access, so it is important to get all the material together to quickly do an IV access if needed. And also, based on the Broslow weight that you have calculated, it is good to write down some of the medication doses in case you need airway medication or you need anti-epileptics if the patient is still seizing by the time they arrive. The difficulty sometimes here is that you really don't know what kind of patient you're getting. It's could be a patient who's stopped seizing already, or it could be a patient who's back to baseline by now, or it could be a patient who's continuing to actively seize. We sometimes don't get follow-up information from the paramedics, so a lot of times we are going to go with the first piece of information that we got. So it's important to know if this patient has a history of seizures, if there's any trauma involved here. Has this patient ever been to our ER before? Maybe we can quickly look at the records and see if there is anything that we can find about this patient. Could this patient have had any recent febrile illness that may be of use for us to know? How long is the total duration of seizure? And of course, if the seizure is still ongoing or not. Finally, I would like to know if the EMS providers have already administered any medication, or is this patient coming without any medication? Going back to seizures and definitions, I think the definitions have changed over time. One thing that pretty much has stayed constant is the fact that seizures are described as either being focal or being generalized. The focal seizures are the ones for which we actually have a specific region of the brain known to be involved. These include temporal lobe epilepsy, for example, or frontal lobe epilepsy. On the other hand, generalized seizures are the ones for which we do not have a specific location in the brain isolated. Those are your generalized tonic-clonic seizures, tonic seizures, atonic seizures, absence seizures, and they're all basically involve impairment of consciousness. So if the patient's consciousness is not impaired, chances are this was not a generalized seizure activity. In 2017, the International League Against Epilepsy came up with some changes in the way they determine the definition of seizures and status epilepticus, and this is based on the onset of seizure. So it basically has to do with how was the seizure initiated? Was it a focal seizure in the onset? Was it a generalized seizure to begin with, or do we not know which way it was? And of course, if it was focal, it's motor or not motor. Generalized, same thing, motor or not motor. And sometimes focal seizures can secondarily generalize. So one type becomes another type. And this was a little bit of a change from before in definition of status epilepticus. When we're talking about trying to define status epilepticus, there are a few factors to consider. Obviously, duration. How long was the seizure? How long should it last before we call it status? Is there a specific type of seizure that lends itself more to being status? Is there a element of response to innervation that can help us decide whether or not this is status or not, and what kind of complications come along with this? In terms of duration, pretty much everybody agrees that the most recent definition of a status epilepticus is any continuous convulsive seizure that lasts at least 5 minutes, or any series of smaller seizures without return to baseline in between. These are considered status epilepticus, and this was defined mostly from the standpoint of needing immediate intervention. In terms of complications, obviously any seizure that has hypotension, hyperthermia, or evidence of increased ICP associated with it is more likely to prolong and to result in deterioration, and therefore be more likely to be classified as status. So what this basically means is that a seizure that lasts longer eventually gets to a point where it causes irreversible neurologic damage. And based of our knowledge currently, mostly on animal studies, we believe that a seizure that lasted at least 30 minutes will start showing up some evidence of irreversible neurologic damage. So therefore, it is important for that seizure to stop within 30 minutes. Also, we know that seizure that lasted 30 minutes or longer is less likely to respond to any kind of therapy or any kind of intervention. So in terms of epidemiology, important things to consider is that seizures and status epilepticus are the most common neurologic emergency in children. Overall, the incidence of seizures is 10 to 40 in 100,000. Mortality of seizures and most likely the status epilepticus is 3 to 5%. We also know that most commonly status epilepticus occurs in children under 2, but even so in under 1, more likely than those who are older. And also this is important to note, but the most common cause of status epilepticus in children is febrile seizure. And we know that is one of the common presentations of seizure to the pediatric emergency department. So it's important to understand that at least 25% of all status epilepticus are from febrile seizures. In terms of risk factors, obviously anybody who's had a previous history of epilepsy is more likely to develop status. Also, patients who have clusters of focal seizures are most likely to become status. As we discussed, also less than 1, febrile seizures also. And focal seizures that start out as focal onset but then secondarily generalized, they're more likely to become status. For those who we monitor background EEG, if there is activity going on in the ENG in an epileptiform sense, they're more likely to become status. Also, patients whose first seizure presentation is a status are higher risk of having ongoing future status epilepticus cases, as well as those who have abnormalities found on MRI. The etiologies are very variable. Of course, fever, which basically means a febrile illness from a virus, any kind of ingestion in small children, ethanol, drugs, adolescents, for example, who take cocaine, that decreases your seizure threshold, making you seize. Also, any kind of medications, some anti-epilepticus themselves increase the likelihood of developing seizure. Any kind of electrolyte imbalance, such as hypoglycemia. So it's important when a patient with seizure arrives to first check a glucose to make sure that's not the cause of seizure, because no amount of anti-epileptic is going to work if the patient continues to be hypoglycemic. Patients who have underlying metabolic disease, patients with CNS infection, and so on. Just one thing to mention that traumatic injuries cause seizures but are less likely to cause status. If they do develop status, that suggests very severe traumatic brain injury. Complications kind of mirror, in a way, etiologies, but a lot of the complications have to do with respiratory and metabolic acidosis and issues related to hypercarbia and electrolyte imbalances. So going back to the case, so this patient we had who was coming in, we now know that upon arrival to the ED, they're still seizing. EMS reports a total of 15 minutes now. Seizure is described as generalized tonic-clonic. The patient is febrile. They have given no treatment en route. We don't know of any previous medical or trauma history, and there's no preceding illness. So based on what we're seeing here, so this is a patient with febrile seizure, which is the most common cause of status. The patient's already been seizing for 15 minutes, so therefore they are in status already. And there's really no other things for us to look for other than the cause of the fever that causes the febrile seizure. So what we do next is we're going to try to establish a line and give some anti-epileptics because apparently no previous medication was given. Our focus will be on stopping the seizure. One thing generally on febrile status epilepticus is that 1 out of every 20 febrile seizures present as status. We also know 1 in 20 children between 6 months and 5 years have had an episode, at least one, of febrile seizure. Usually there is no long-term complications from having febrile seizure, and febrile seizure is not an independent risk factor for epilepsy. Sometimes, we have to understand that etiology of febrile seizure is related to the infection itself. So our goal is to bring the temperature down and give some antipyretic and find underlying cause of fever to prevent any further problems with this. In terms of diagnostic consideration, there's a lot of things to check. This is not just for febrile seizure, but any kind of person who's coming with fever. Any person who's coming with seizure. So we do point of care glucose to make sure hypoglycemia is not the cause of this. Check electrolytes, check blood gas. Important to check the end-tidal CO2 to see whether or not there is respiratory depression or respiratory failure going on, which we need to support, as well as a series of other labs, as you can see here. Just one thing that's very important is that some of these patients who are on anti-epileptic medications already may have subtherapeutic levels that contribute to status. Also, sometimes these medications themselves decrease seizure threshold. So adolescents, for example, who are taking carbamazepine, if they accidentally overdose, they might cause themselves to have a seizure. So bottom line is find the possible underlying treatable condition, find the fastest way to stop the seizure. And we know the first line agents typically are benzodiazepines. Benzodiazepines are extremely effective in a lot of seizures. Remember that you can give a dose of benzos and then repeat it again in 5 minutes. So 2 doses at the minimum before you start worrying about needing to do more. If you have an IV established, then lorazepam, diazepam, and midazolam are all equally effective, and these doses are listed there for you. If you don't have an IV access, I would say that midazolam is much more appropriate to use than lorazepam. Midazolam works in pretty quickly intramuscular as well. You can also give it intranasal. The problem with lorazepam is that an IM, it has slow onset of action and also has a depot effect. So it doesn't really help you in the immediate time, but it might also have very irregular and unpredictable activity given as an IM. So if there is a line, you can give lorazepam, but if it isn't a line, there's an IM that you have to give, probably better to go with your midazolam. So back to the case again. So the patient who has febrile seizure, we gave him acetaminophen. We checked the point of care glucose, which was okay. We started a saline bolus. We sent some labs out. And we have now given 2 doses of midazolam, but the patient is still seizing. And remember, we said after we've given a couple of doses of midazolam, which we were able to do every 5 minutes, technically what we could do is we could give more, but every more doses of benzos can contribute to cumulative respiratory depression. So you have to start preparing for airway if you're going to do that. But it's now time to get to the second agent. And remember, after 10 minutes of status, it's appropriate to start doing the second agent. So that means you wait 10 minutes, 2 doses of the benzodiazepines, and if that was not stopping the seizure, it is appropriate to go to the second line. In terms of second line, there are 3 medications that are equally effective, and the dose equivalence of 20 milliequivalents of phenytoin equivalents of phosphenicoin loading dose, or 40 milligram per kilo loading dose of valproic acid, or 60 milligram per kilo loading dose of levetiracetam or Keppra. are useful. Other possibilities, less used though, is phenytoin, 20 per kilo. You have to push that slower because of the local tissue issues and phlebitis and all the other issues related to propylene glycol diluent that's in the phenytoin. Also, IV phenobarbital can be used, especially a lot of adult EM folks who treat kids. They do go with phenobarbital. I have not used that as my second line, but if I do want to use it, I stay closer to the 5 milligram dose, because the closer you get to 20 milligram per kilo, the more likely it is that you get respiratory depression and have to protect the airway. So use it by all means, but just remember that high dose of phenobarbital, if you use, may require airway security, and if you're comfortable with phenobarbital, is a very appropriate choice. Also in neonates, phenobarbital is a second or maybe even a first line sometimes, because neonates less than 28 days respond really well to phenobarbital for stopping seizures. The third lines, which usually require airway to be protected, are propofol and pentobarb. I have used pentobarb myself a few times, and that's initially the pentobarb coma, which you give an initial dose and then you have to go ongoing dose. Remember, myocardial depression and decreased cardiac output with pentobarb requires this really to be done in an intensive care setting. Same thing with propofol, acidemia and pulmonary edema to be concerned with. So it's a great drug, propofol, but you remember, again, it has to be done in very, very intensive care type settings in terms of observation. Some of the new medications that are emerging in the horizon, ketamine, for example, at a dose of 1.5 per kilo loading dose, may be an alternative. Some people even use the combination of ketamine and propofol by giving 1 per kilo of ketamine and 0.5 of propofol, give a ketofol, which may be better tolerated than the propofol itself. This is something also, if your institution has, would be a legitimate choice. Others include lacosamide and topiramate. Just remember, if a patient needed to get these medications, and essentially this would be ceasing all activities and protecting the airways, this patient needs to go on a suppression burst of at least 24 hours. So for 24 hours, you keep dripping these medications. Don't bring the patient out. And after 24 hours, you can dial down the meds and see if the patient's seizure baseline has stopped. And during this time, of course, you'll be doing continuous EEG monitoring as well. In terms of airway, you always have to think about the airway. There are two ways really to do airway. One is passive oxygenation, if the issue is oxygenation and not airway patency. If the airway is open and all you have to do is get the oxygen in, you can do passively by blow-by or nasal cannula or non-rebreather or simple face mask. If the patient requires more of a positive pressure, then you have to do bag mask ventilation, or if there's obstruction and you can't get to the trachea, you probably will use a laryngeal mask airway. If you can easily intubate, then endotracheal intubation is a worthwhile approach to have immediately. The goal is not to intubate somebody if you don't have to. However, there becomes a time where you basically have to intubate. Severe respiratory failure, and that's again a judgment call, but if you have somebody whose respiratory rate is 6 and they're not making adequate chest rise, it doesn't look like they're doing it for themselves and you have to actively get involved, you probably need to intubate them. Also, hypercarbia, PCO2 greater than 60 is an indication for having endotracheal intubation. Obviously, for that, you need blood gas measurements. And if the issue was just basically to create patency, remember sometimes when somebody seizes and when the seizure is ending, all the throat muscles start relaxing and the tongue falls back into the back of the throat and may actually obstruct the airway. So something like an oropharyngeal airway or a nasopharyngeal airway or a nasal trumpet or sometimes laryngeal masks are useful to open the area for better respiratory exchange. And this, again, remember, these are not primary modalities. These are adjunct. These are temporary. And you need to have more definitive airway options. So going back to the case now, you basically gave the patient the medications you needed to. The seizure has apparently stopped. The patient seems sleepy now, sounds potentially post-ictal, and has some mild snoring. you notice that oxygen level is starting to look lower and you have good waveform, so you know it's actually reading correctly, and it's reading 87% on room air. And patient does not look like to be in any respiratory distress, and the respiratory rate is 14, making adequate excursions, and end-tidal CO2 is 37. What do you do next? Okay, so remember in this case, the patient look like they're maintaining their airway. They have no distress. Their respiratory rate is good. They are not hypercarbic. It is just a matter of O2 sats. So in this case, what I would do is basically simply put the patient on some nasal cannula oxygen. You could start with non-rebreather at 100% and titrate down to as needed. I have found, and I've had several of these patients, I found that with the excess of medication given, that you end up having a transient hypoxemia. So giving 1 to 2 liters of nasal cannula usually is pretty effective. And after that, you basically watch them, monitor them for a little bit, and you might be able to get them off the oxygen. Of course, if they deteriorate, you escalate from there. So when the seizure has stopped, then what you have to do basically is take a note of the airway and the respiratory status and oxygenation like we just talked about. You have to also make a decision on whether or not this patient is postictal, or they just stopped having visible tonic-clonic seizures, but they're still having what we call subclinical seizures or electrical seizures, which unless you have an EEG monitor, it's hard to say. So you have to kind of look at whether the patient's jaw is clenched, whether the eyes are still flickering, because from one end, you don't want to over sedate. From other point, you don't want to have the patient keep seizing. That is a very difficult balance and kind of is experience based. But a lot of time that is a temporary situation. So if you're going to keep giving more and more anti-epileptics, just remember that you have the airway to worry about at that point. Then there's the issue of stabilizing, what the ongoing support are. For example, somebody who seized about 30 minutes and you either intubated or you're close to, probably needs to be admitted, most likely to the ICU setting. You have to think of what is the chance of this recurring and what is going to be the disposition for this kind of a patient. And if your hospital doesn't have an ICU or you don't have the capabilities to deal with it, then that patient needs to be transferred. If you have transfer agreements with a tertiary care children's hospital, for example, you may consider having their transport team come and get the patient just because of the risk of having re-seizures. It's hard to go with private ambulance systems unless you know them and you've worked with them before in terms of a critically ill child potentially. So that is a call that you'll make on your own institution level. Quickly, one last thing about neonatal seizures. They are more common than seizures in the post-neonatal age, especially preemie kids are at a much higher risk of seizing. You can treat those same way with benzodiazepine, but remember, remember that the phenobarbital comes earlier in that, usually either first line or second line, and the rest of the medications are similar. Just to conclude, for the purpose of ED treatment, status epilepticus is defined as 5 minutes of continuous convulsion or failure to return to baseline. It's most common as a part of febrile seizure. Status epilepticus lasting longer than 30 minutes is a risk factor for irreversible neuronal damage or death. Benzodiazepines are the first line. You can give them twice before you move to the second agent. Remember, 10 minutes in seizing, you can go to the second agent. The goal is to have the seizure stop within 20 minutes by the benzos. Second lines, as we mentioned, equal efficacy with fosphenytoin, valproic acid, and levetiracetam. Airway protection should be considered for refractory status epilepticus and prior to third line being initiated. And that's a list of my references.